That's what I look like in the bottom left. So if Zeb or Sujin or others can see this and ping me that you see me as advertised, looking somewhat like I've had a nice day, and my current status in my home office. I want to thank those who supported this work, NSF, NIH, Simons, Aero, and really the most important thing I can do at the outset is to thank folks on my team at Georgia Tech as well as collaborators, both at Georgia Tech, those elsewhere, Jonathan Dushov, McMaster, former postdocs Jehun, Exon, and others. So to begin, I want to provide some context. The context is that a few months ago, situation reports started to come out of the World Health Organization. You can see one example here. This has about 37,500 cases, 25 countries, largely focused in Asia. Moving 2 months forward, on April 9th, you can see the situation again as reported by the WHO. We're almost 1.5 million confirmed reported cases and 85,000 deaths. And obviously, this has become a global pandemic, not restricted to any one particular region, but really affecting the globe. Just 5 days after that April 9th report, you can see the pace is quickening. This is a feature of epidemics that grow nonlinearly and exponentially. That 400,000 cases and 30,000 new deaths were reported in the 5 days since the April 9th report. So what I'm going to do today, and I apologize for the technical difficulties at the beginning. It seems though that I've gotten about 10 emails saying that people can hear me just fine, which is good, is I will try to do 3 things. First of all, just to explain, this is a nonlinear dynamics and seminar, so I will do my best to try to explain some of the dynamical foundations of epidemics. I will try to avoid deep technical details, but trying to give everyone on this call an intuition to understand some of the numbers and concepts and ideas that go in to understanding the spread of an epidemic and why there's not just one number that can describe how an epidemic might unfold. And in fact, I'll try to focus on 3. From there, I'll move on to dynamics and control, meaning how we got to the point where we are right now, and also think forward, not just weeks, but months and even beyond, of ways out of where we are now in the absence of pharmaceutical interventions. So I'll start with this first part on dynamical foundations. And again, going back a few months, this is a report from the New York Times comparing what you've probably heard, this basic reproductive number on the x-axis, which is equal to the average number of new infections per sick persons on average. And this is always indirectly measured. You can think of this as the epidemic potential from the individual's perspective. So the number 5 there on the x-axis means that for every individual who's sick at the outset of the epidemic, they're going to make 5 new people sick. And those 5 people will make 5 other new people sick. So you get to 25 and 125, 625, and so on. The y-axis is the fatality rate, directly measured, meaning what fraction of individuals who get sick will die. And for some diseases, like Ebola virus disease, this is quite severe, 50% or more. For others, the common cold is basically irrelevant. And this coronavirus, COVID-19, or the causative agent SARS-CoV-2, has an unknown, and now we're zooming down a little bit on this, but it's often hard to even measure the fatality rate because this depends on figuring out who was infected and who died, and there are delays, but there's also ascertainment problems. The challenge, though, is that it is both a highly spreadable disease in the sense that its R0 number may be relatively large, but also causes mortality. And this is precisely what made many people concerned from the very outset. So the question that motivated a number of work at the beginning was how certain can we be about this R0 number? Because this tells us a lot about how much work we're going to have to do to control the disease and how bad it might become if it continues to spread. And to explain this concept of why there's a difference between what we observe and what we indirectly measure, here I've put together a synthetic epidemic outbreak. Over time, the y-axis is the number of cases, and the red line is the expected value. The black dots represent measurements that one might find on different days in terms of the number of infected cases. And here, this is an example of R0 1.5, so 1.5 new cases per every individual case in an otherwise susceptible population. In this next panel, I've shown the same thing with R0 2, and the third R0 2.5, and I haven't made a mistake. And you'll notice these all look exactly the same because they are. Because what actually has happened here by construction and by intention is that these three synthetic outbreaks all have the same initial growth rate, meaning the number of infected individuals seems to grow exponentially. That's what we measure. But yet the underlying mechanism differ. And this is an identifiability problem that happens because speed, the rate at which we see new cases arise, is not the same thing as strength, which is this R naught. And in this one picture, I hope to explain those three concepts. The speed of the epidemic is how fast the cases double. The strength is really the epidemic potential from an individual point of view, whereas the speed is its potential from the population view. And then the size is where these three different cases begin to differ, meaning an epidemic with a larger R naught, that an individual tends to infect more individuals, will lead to a larger epidemic outbreak down the road. And you'll see also that then the larger R naught means that the duration lasts longer as well. Okay? So we have three different concepts, and they're not the same, though they're obviously related. And so the idea here is that many values of R naught can be compatible with the same observed rate of increase at the beginning, even if the outbreak sizes are different. To understand this, I'm going to introduce the simplest of these classes of epidemic box models or compartment models, in which you take individuals in a population and you envision that they're broken down into three categories: susceptible, infectious, and recovered, which I use the shorthand SIR here. Infectious individuals come in contact with susceptible individuals at some transmission rate beta, leading to new infections, and infectious individuals recover over some characteristic time scale. Again, those are the three classes, and there are two mechanisms: infection and recovery. Quite a lot more goes into COVID-19, and I'll explain that soon as well. The idea that if we think about then the expected number of cases, that depends, and that change, that I dot, depends on the current number of infected individuals times the difference between this basic reproductive R naught minus 1 over a characteristic time scale, where the R naught is the infections per time times the infectious period. So you see, if you're infecting 4 per day and the infectious period is 2 days, R naught would be 8. Whereas if it's 0.25 or 1/4 and there's an 8-day infectious period, that would be an R naught of 2. And as you can see from this very simple linearized dynamics around the naive set point, which is the fixed point at the beginning where nearly everyone, and in our case, really, we should think that everyone is immunologically naive, R naught should be greater than 1 for this disease to spread, which is what you see there on the right. A disease will spread whenever the average number of new cases exceeds 1, right? R naught greater than 1, and the increase, at least at first, is expected to be exponential. And when it's less than 1, then the decline is expected to be fast, exponentially fast, to elimination. So at the outset for COVID-19, I'm giving you 7 examples of studies that took the same data or similar kinds of data and found very different estimates of this basic reproductive number. They use different methods, branching process, SEIR models like SEIR, but with an asymptomatic class or an exposed class, other sorts of assumptions. And they got very different outputs, and you can see they differ quite a bit, from everything like 1.5 to something like 7. That is going to be very different kinds of implications for the effort of control. It turns out that these model choices also made very different latent assumptions. They assume different things about the etiology of the disease. In other words, how long an individual, after they've been infected, typically it takes before they infect someone else. And there's a distribution there, but it has a mean and a dispersion. And they differed in those. And it turns out that that really is part of the answer, and why there's a lot of uncertainty often at the beginning when we're not quite sure exactly how long it's taking between when someone gets exposed and infected and when they infect other individuals. And the brief answer to this that explains this variation is that speed and strength are linked. And you can see this here in a very simple example in which there's weekly incidence. The incidence we observe is exactly the same, but the reproduction number we infer differs, and it is correlated to the generation interval. In other words, if the time between when someone is infected and they infect someone else is short, then the reproduction number, paradoxically, is smaller, because it means more generations have occurred in order to yield to the same realized incidence growth rate. Whereas if the generation intervals are longer, there are fewer generations of me infecting someone else and that person infecting someone else. And so therefore, in terms of the average number of new individuals infected per generation, that actually goes up. So there's a connection here between speed and strength. Shorter generation intervals given an observed speed means lower reproduction number. Longer generation intervals given an observed speed means higher reproduction number. This also begins to explain things that, for example, just came out last week and made a lot of hay. In the bottom right, there's a Forbes article. There were many other such articles that said COVID-19 may be twice as contagious as we thought. I don't think so. The issue is that this report that came out in Emergent Infectious Disease claimed that the R0 was about 6. Now that is very hard. That means each individual on average is infecting 6 people, and that's twice as challenging to control as an R0 of 3, and especially with other control measures in place, this would be quite difficult to tackle. But if you look on the left, what you see is exactly what I just described, that there are not estimate that green and red and blue means longer periods between when someone is infected and when they infect the next person. Here they're using serial intervals and generation intervals. That's a technical detail for another day. The whole point is that the assumptions matter. And I hope this helped. The simple idea helps you sort through putatively large claims about R0. It's probably that they're making an assumption that it takes a very long time between when someone gets sick and the next person gets sick. And when that's the case, by definition, R0 must go up. What we've done, and this work with Sungwoo Park at Princeton and Jonathan Dushoff at McMaster, is essentially think about the uncertainty and the estimated growth rate, the generation interval, and this coefficient of variation, and from the outset found that despite these differences, an R0, at least at the beginning, is something about 3 with confidence intervals around 2 to 4.5. And this helps to make sense of why, studies may differ at the beginning, why there can be uncertainty, precisely because people are using different data measured for growth rate, but also different assumptions about how long it takes between when one person gets infected and they start to infect others. Okay? And this is, from the very outset, one of the concerns, but now we're moving, obviously, into a new phase. So I've described in this first part the concepts of strength, speed, and size, meaning speed, the observed rate of cases that we can measure, and I'll get back to that at the end because it's very clear that the total case count is not the same as the actual case count. There's an ascertainment issue. The strength, which is a measure of epidemic potential at the individual scale, and then the size, which is what we're worried about averting in the long term. And that's what I want to talk about in part 2, dynamics and control, how we got to where we are now. The same condition for epidemic growth, this R0 condition being greater than 1, which I'll remind you is the infections per time multiplied by the infectious period. Right, so the number of new transmitted cases per unit time multiplied the infection period. And this infection per time is a product itself of many things. Contacts by infectious individuals per unit time. The probability of contact with a susceptible. And at the beginning, almost everyone is susceptible. And the probability that that contact transmits the disease. Each of these elements suggests opportunities for control. And depending on the disease, different parts of these components may be operational. In the absence of effective treatment, or in the absence of a vaccine, then usually one goes down to the second stuff down below, which are non-pharmaceutical interventions. How do we reduce contacts by infectious individuals? Well, we have to find them, and we have to isolate them before they start interacting with other people. How do you reduce the probability of contact with a susceptible? Quarantine, travel control, closures, all the things that keep people away from each other, and especially keep people who are susceptible away from people that might infect them. And then if a contact does happen, how do you de-risk, in some sense, that contact? And that gets into process engineering, washing hands, masks, other kind of protective gear. And I should point out, and I know Georgia Tech has been doing wonderful work on that last category. In many cases, it's true in Ebola virus disease, that means that these other opportunities to control a potential transmission event have been missed. So the more that we can do earlier in the chain, the less we're going to put a burden on the PPE, on the hospitals, etc. That's what I'll be focusing on today. One of the reasons why we're here now, and when I say here, meaning you in your homes, me in my home, and this is the same in many places throughout the world, is that an epidemic spread of something that has an R0 of anywhere between 2.4 or 3 or above, with a case fatality rate about 1%, means that we have a serious problem. And the scale of the problem, I think, was highlighted effectively by the Imperial College of London Model Forecast, which came out in early March, and they've been working on it for quite some time. And functionally, they've been advising governments even well before then. The idea is that if we go about business as usual, and the chances of us going about business as usual is low when people start to realize, even without any interventions, that folks are dying at high rates, is that the 80% infected, which is what would be expected for an R0 of about 2.4, implies that if you take the US population, assume 80% infected over the course of the epidemic, and have something like even a little bit less than a 1% incident fatality rate, you get 2 million plus fatalities in the United States alone. And this also means that for a place like Georgia, which has about 11 million individuals, you can also do the math and you can see that we're talking about tens of thousands of potential fatalities at a state level, 2 million or more or upwards, again, in this unmitigated case. Now, this sounds like a lot, and it is a lot. And these are really worst case scenarios, and they're not meant to be forecasts. This is not what we think is going to happen. This is what we're trying to avert. And I want to go back a few years. This is back in 2014, where there was a Nature brief editorial that said models overestimate Ebola cases. And I don't think it would be hard to just take this article and replace the word Ebola with coronavirus cases, given the way that some have interpreted what these models are doing. So let me try to shift and emphasize what I think these models are trying to do. The Imperial College of London model doesn't stop and say that's the outcome. It explains the need, scope, and outcome of what might happen with different kinds of interventions. And there are assumptions built in, reasonable assumptions, but assumptions nonetheless. This is an example of an effort they tried to do to show how different kinds of actions and interventions might change critical care beds occupied per 100,000 individuals. As you probably have heard of, this notion of flattening the curve is not only to reduce fatalities, but also to make sure that healthcare services are not overwhelmed. And what they've tried to show here is that different levels of case isolation alone probably are not enough, with household quarantine, closing schools and universities, that a combination of factors are going to happen in order to reduce spread. And we've seen extraordinary steps along these lines. So again, April 2nd, 2020, don't believe the COVID-19 models. Now it's the Atlantic, so they had a clickbait title, but they knew what they were doing, and underneath they had the subtitle, that's not what they're for. And this is a viral tweet that came out, new cases time, and with prevention and precaution efforts, as things get better, see, it wasn't so bad, we overreacted. So keep in mind that when there starts to be a gap between what models had predicted in the event of no interventions versus what we see, that should be a sign that people have taken it seriously, not that the models were wrong. That's not what they were for. So I now want to go into what do we think the evidence is that the interventions have had impacts and what kind of impacts have they had. And I'll try to do this in a couple of contexts covering broadly. I mean, there's a lot of material here to cover, but I'll try to give some of the highlights in ways in which models have started to treat not only the forecasting, but also dealing with evidence of interventions and their relationship to change in cases. The earliest examples of effective interventions come from China, with a focus on the center of the outbreak in Wuhan. What you can see in the top panel, and this is a paper that came out in late March by Sam Scarpino and colleagues. It's Kramer et al. With the link on the bottom left. And what you can see is that there's a change in the pre-cordon sanitaire from a growth rate that was positive to one that was below. also giving some sense of the rapid ways in which travel was then restricted and controlled in a very short, more or less 2-week period of time, from large-scale migration to less. In the C panel, what you see is the correlation between migration and cases. And so in essence, at the outset, what this is trying to communicate is that migration rapidly spread cases, so that most of the cases were due to immigration, importation of cases. And then the correlation broke down because of the cordon sanitaire, and instead community transmission became the dominant factor. And that's an important thing to keep in mind, that early in an epidemic, stopping importation of cases can make a difference because most cases will be imported or due to those imported cases. But rapidly, community transmission becomes much more important. So the notion, which I think was dealt with early, and maybe not just maybe, not early enough, was the idea that if we could only stop imported cases, shut down travel from China, which turned out not actually to be the case, and not from other places, that would be enough. That was clearly not going to be enough. Community transmission was happening. It was documented in Washington early by Trevor Bedford and others, and it continues to happen everywhere now. It is the dominant factor. When a new case happens, it's almost certainly due at this point to community transmission. So then what are we doing about community transmission? This is now the Imperial College of London report looking at 11 different countries. I'm just giving you 4 of the panels here, showing how much of the reduction in the basic reproduction numbers happening by first and later interventions, and really showing the differences in the kinds of impacts they think are happening vis-a-vis different kinds of intervention measures, with lockdown being the one that has the greatest effect. And their estimate, based on projections of cases only through the end of March, is we're talking about tens, if not hundreds of thousands of averted fatalities due to changes in behavior, and many more deaths will be averted by ensuring that these remain in place until transmission drops to low levels. That's another example that this effort, a severe effort, is really trying to avert, and with some evidence that the outcomes were going in a direction we're talking about severe consequences, catastrophic consequences, have at least temporarily been averted through these other severe actions. Similar groups have made analyses of data in a national scope. This is INSERM data from the Ile-de-France region, led by Vittoria Coleza and her team. And again, what you can see here, hospital admission data, weekly incidence of cases with baseline and a lockdown scenario, along with confidence intervals, showing that instead of talking about 10, 20, or getting close to herd immunity levels with catastrophic consequences given incidence fatality rate, instead, the percentage of the population infected is somewhere between 2 and 5%. You've probably seen some of the data already from Italy. It may already be in excess of 10% in Italy. But the idea here is that these lockdown level of interventions have shifted the curve away from perilous exponential-like growth to something severe. It's serious, as we all know, but still at the level 2 to 5% infected, and in some cases plateauing and even going down on a week-to-week basis. There are still deep uncertainties there. Those are 3 different examples. I could give more. One of the things that make COVID-19 very hard to both to predict and control is that this is not an SIR-like disease. One of the key things that makes it different and challenging is that there's asymptomatic transmission. And asymptomatic or mild or subclinical or even pre-symptomatic transmission are all different ways to say something about the fact that individuals who may not have symptoms yet, in some cases may never have symptoms that they would classify as being severe, or certainly a clinician would say not severe enough to come to a clinic or a hospital, nonetheless can transmit. What I've shown here in this diagram is a variation of these SIR models, and one that we use operationally, and groups use variations of these kind of models, in which susceptible individuals become exposed, and here with some probability they may have an asymptomatic infection and one that has a symptomatic or more severe infection. And those asymptomatic individuals may recover and in fact never know that they've been sick, or not sure, or suspect that they might have been sick but not quite sure. Even those with severe symptoms may never have been tested for COVID-19, but some subset of them will end up having severe enough infections that need to go to a hospital. Some of those may be subcritical, some may be critical to the point that they need to go to the ICU and be intubated, and some fraction of those that are critical will recover, and some fraction will die. This kind of transmission chain obviously means that this route, this asymptomatic route, which can then lead to forward transmission, becomes something that's hard to do, the kind of typical case control in terms of isolating infectious cases if one's not sure, both because of testing, but also because of symptoms, who precisely is sick. So I'm going to take one brief interlude for technical reasons. This is, again, in this nonlinear dynamics seminar context. And so far, I haven't gotten any other emails, just looking to make sure that I can still be heard. So if Zeb or Cleo or Devika or Sujin are listening, and just ping me that you can still hear me, that would be terrific. I'm assuming.
Okay, we hear you.
Good. Okay, thank you, Predrag. So what I want to explain now is just a little bit of how folks who work on these epidemics think about asymptomatic impacts. And one can think about it in terms of a system of nonlinear ODEs. We're also using something which is called a renewal equation, which says that the change in the number of susceptible individuals, in other words, that decrease due to new infections, has to do with individuals who were infected a certain time ago, and then the time over which that they typically infect other individuals, and that may differ between asymptomatic and symptomatic. It may be that asymptomatic have very short, highly resolvable infections, or they may be asymptomatic for a long time. So the duration of asymptomatic and symptomatic do not necessarily coincide. And it turns out that the exponential growth helps us to be able to solve, or at least pose how to solve these problems, because if we think that the I's, all those total infectives or infected asymptomatic or symptomatic, are growing exponentially, it's possible to connect three things. The R naught, which is the strength, which we don't know, we're trying to understand, to the speed R, which we measure because we're measuring this doubling rate of cases, so we measure that, and what we assume is this generation interval G of tau. And it turns out that one can recast this problem in terms of this renewal equation and figure out, given an observed R and assume G, what R naught is, and with some variation. And that's what I've shown here on the right. The x-axis is the relative duration, essentially, of asymptomatic infections relative to symptomatic infections. And it turns out if asymptomatic infections are relatively short, this goes back to the speed-strength relationship I mentioned at the very beginning, then we've probably overestimated R naught, and it's probably a lower R naught than we think. Whereas if they tend to be longer, then we've probably underestimated R naught. So one of the most important takeaways here, and that's on the x-axis, and I'll just mention the y-axis, is the intrinsic proportion of asymptomatic transmission, which is slightly different than the probability that a newly infected individual will be asymptomatic, but it's related to it. And the idea here is that we shouldn't be striving only to figure out what fraction of cases, new cases, are asymptomatic, but also their duration. Because this then, as you can see, means that we could be significantly underestimating or overestimating the R naught, and also biasing our sense of how much of our control effort should be focusing on symptomatic versus asymptomatic individuals. And so the takeaway here is that asymptomatic transmission really is a double-edged sword. It means, as people have noted, maybe it's not as bad as we think, that their infected fatality ratio is lower. That may be true, but it also means there are going to be many more cases. And it's really the product of cases and infected fatality ratio that leads to cumulative death rates. And it also means differences for how we both approach the R naught estimation, but more importantly, the control. And this is work that's, again, with Sungwoo Park and Cornforth here at Georgia Tech, Jonathan Dushoff, and its impress at epidemics. So we've taken this idea, again, to try to measure the impact of interventions and integrated into a COVID-19 model with asymptomatic transmission, applied it to Georgia's age demographics, along with age stratified risk, the fact that older individuals are much more likely to have severe outcomes. We also think that they're more likely to have symptomatic rather than asymptomatic outcomes. And what I'm showing on the right, and if you follow me on Twitter, you probably have seen me tweeting out versions of these. On March 28th, we went back and tried to take data with respect to where the cumulative deaths, hospitalizations, and reported cases were, and then fit what we thought was the latent, unobservable state of the system and project forward given different kinds of scenarios, from baseline to 25, 50, or 75% reduction in contacts due to the combination of social distancing and then now shelter in place that is happening first in Atlanta and other localities and then statewide. And I want to point out a few things based on at least this scenario, and there are others, not showing confidence intervals at present, but these are really scenarios. You can see that both the reported deaths and hospitalizations are consistent with something like about 50% reduction in contacts, in other words, 50% reduction in transmission. Depending on other scenarios, it could even suggest that we've reduced it by 75%. However, the case count doesn't seem to follow on that same line. And I want to point out here that we fit this model, we fit it to deaths and hospitalizations, and then for many reasons thought that the number of cases reported had little bearing on the underlying number of cases in the state, that we were severely under ascertaining the caseload and prevalence. And so the points I want to make here shows that deaths and hospitalizations, which are bad, if you can see here already, we're approaching 500 or more deaths due to COVID-19 in a relatively short period of time. If you've looked at data of New York City, you can see similar things, and it likely is much worse, given that there are many cases that have not been attributed. So even death counts that are being reported, whether it's on the Department of Public Health site or in the COVID tracker dashboards, etc., are almost certainly underestimates. And in fact, work on all-cause mortality is really going to start telling some of the tale. And right now, it's quite bad. But one should be following those all-cause mortalities in the long run to get some sense of cumulative impact. So that's the first case. I wanted to make that point, but also that those actual outcomes consistent with forecasts of impacts of contact reduction, you can see we're talking about 2-to-1 and soon 3 or 4 or 5-to-1 averted deaths for each death that occurred. So the news is not good, but at least we've been taking steps to avert much worse outcomes. The other point I want to make here is that the ascertainment rate may be 10% or even just a few percent. So when we first fit the data and there was a few thousand cases, in order to make sense of the number of reported cases, hospitalizations, and death, it implied that we're, in fact, probably something already like 100,000 cases. And now we've gone up by a number of factors, such that now I think it's more likely that we have somewhere between 1 to 4% prevalence in Georgia versus the nominal prevalence if you just take the laboratory confirmed finding and divide by the Georgia population, and you get something like 0.1 or 0.2%. I think that's almost certainly a strong underestimate of the true prevalence in the state. We are continuing to take these models and then move them from the state level, and with the help and collaboration of Cleo Andres, who's in Georgia Tech's Interactive Computing and Design, along with Stephen Beckett, who's been leading this in terms of the effort of building a metapopulation model at the level of counties, we're able to take data back on March 28th and project forward what would happen in terms of county level deaths versus what we think might happen if one keeps into account systemic 40% reduction of contact rates throughout the state. And you'll notice that we're starting at the baseline of Metro Atlanta in terms of absolute numbers and near to Albany and Dougherty County and nearby as being hotspots for total cases. And for those of you who've been following it, per capita, Southwest Georgia is even worse. Right now, I'm showing here total numbers, not per capita, but the per capita numbers are 5 to 10-fold higher in Southwest Georgia, unfortunately. There's many reasons for that. We're going to be releasing this report soon. We already have released visualizations of this county level data on our GitHub site, and you can see the link at the bottom, or just go to weittzgroup.github.io, either cases.html or desk.html to see this by county over time. And the last thing I want to say about the state of the situation now, does my country or county have an epidemic? And here I've written my country at the top, and the graphic below is county, so apologies, extra R, but I think whether it's country or county, the answer is yes. This is work by Lauren Myers and colleagues at UT Austin. The idea is that given this ascertainment bias of the kind that I just described in Georgia, it's almost certain, even if there are no reported cases or just a few, that the actual number of cases is much larger. So waiting to impose lockdowns, social distancing, other shelter-in-place measures until the observed case counts get high is already far too late, and the impacts of those kind of waiting, essentially waiting for cases to be high before one act, are also severe, because the consequences of waiting are exponentially magnified given the nature of spread. So I've gone through the first two parts, and I know I'm moving fast. And again, I will release these slides on as a Figshare element afterwards, and look either at my Twitter or GitHub site to find out more. But I do want to talk about long-term strategies. I've talked about the foundations, how we got to where we are now in terms of interventions that have reduced and averted worse scenarios, but the current scenario also has its challenges. And to give at least some perspective on how we might collectively get out, insofar as there remains an absence of pharmaceutical interventions. And I know I've heard there's a report out of Oxford of an individual who has a great reputation talking about a potential vaccine by September, October. If so, it would be wonderful. That group, let them win the Nobel Prize. We should all be better off. However, I think we should prepare for the worst while hoping for the best, in the sense that typical schedules suggest this might be a year plus effort. And in that case, we have to think hard about how there's going to be collective balance of trying to both reduce transmission, but also enable some form of economic re-engagement. One of the challenges here, and this goes back to the imperial model, is what are the long-term prospects? Let's say, for example, that one takes a very hard, essentially, social distancing, quarantine, shelter-in-order stance in order to preserve critical healthcare resources. And this is an example in that blue where these intensive quarantine and lockdowns are in place for a long time and then released. The problem with releasing them is the point of the lockdown was to avert large-scale infections. But because of that, in the fall, in this model, the population remains largely immunologically naive, and there can be a second wave. And even if there's not a second wave, there can still be plateaus, because in the absence of herd immunity, and we're very far from herd immunity, we want to work very hard to avoid herd immunity, because to get there would come with severe consequences. But it does mean that one is facing this challenge. In the absence of a vaccine and an immunologically naive population with R naught of 3 and an incident fatality ratio of about 1%, other strategies will need to be put in place, and business as usual is not one of them. This does also mean that there's been talk of really a zero-sum dichotomy. Either we shelter in place and we try to control the infection, or as was, you can see here in the upper right in this cartoon, was the Dow to die for today or what, right? There is a real tension between efforts that have, as I've shown, made an enormous impact in averting infections, hospitalizations, and deaths on the one hand, also with severe consequences, at least in the United States, in terms of millions, tens of millions of jobless claims, hits to economy, other forms of impacts on social order and well-being. And although the consequences can differ based on political choices on how to deal with stimulus packages and how to deal with healthcare and how to deal with job availability and income, nonetheless, sheltering in place does come with severe consequences. There are some models that have suggested that the worst is soon to come and then pass. And I want to bring one to your attention as really the perils of exit scenarios and forecasting. This is a widely known, if not the most widely known model. It's the Institute for Health Metrics Evaluation model from the University of Washington. And on March 28th, predicted April 15th as the peak with about 2,000 deaths per day. That's about how many reported deaths there were on COVID tracking. And in that sense, in that near term, this model can be effective. And I think there are many things about this model that can be effective because they were able to think very carefully about ICUs. They thought very carefully about the impact that their model would have on trying to essentially galvanize efforts to get more PPE and more resources to hospitals, and all those things are good. What's challenging, though, is that if one now looks in an updated model as to what might happen, you'll see that these error bars, not only are they looking kind of strange, but also by June 1, there's no more uncertainty. It's over in some sense. Now, there's a problem there if people expect that if we just do this till June 1, it'll be done. We're back in the same condition as an immunologically naive population. And in fact, the reason why this uncertainty goes down is because this is not a mechanistic model. It's a model which fits a curve to the deaths, and it fits the curve to the ERF function. And for those of you familiar, this essentially is assuming a Gaussian-like behavior where things go up and go down, and then they're done. To analogize poorly, it's as if a tornado passes as part of a storm front, and then the danger is past, certainly. If we go back to business as usual, we pull the tornado back towards us. Right? We remain just as immunologically naive in this scenario at June 1 as before, and there's no way that we're going to have this much certainty. So I just want to offer buyer beware. This kind of ERF curve fitting is useful insofar as used for short-term predictions. And its utility, I would argue, is past the expiration date. And it's not going to guide policy because after June 1 in these scenarios, if we go back to business as usual thinking that the worst has passed, the worst will then reemerge. The future is not that certain yet. There are, however, alternatives. I'll call them more thoughtful exit scenarios in forecasting. And if you'll notice already, even the time scale is different. They're thinking forward an entire year about different kinds of scenarios that combine interventions, lockdowns, to some extent school closures and isolations of different kinds, trying to understand over a long period what options there are for keeping both ICU bed requirements low out of this critical phase, but also averting bounce backs, whether because one is alternating between lockdowns and non-lockdowns or by sustaining different scenarios. This is applied to the Ile-de-France region. Again, this is the Predrag Cvitanovic group, EPICX lab at INSERM, but other similar approaches are going to be needed that combine strategically and thinking really on this 1-year time period. Another thoughtful approach is Christoph Fraser's proposal to use digital contact tracing. And I think this just goes back to a larger idea that testing and tracing are a means of prevention and not just for pathology reports. The more testing and tracing one does, the less then one has to think about pathology reports. There's a schematic in the bottom left, but the idea is that certainly conventional contact tracing gets to be very hard, if not impossible, when one is not just dealing with a few dozen or hundreds or even thousands of cases, but thousands to tens of thousands. And the delay time matters. The longer, given especially the same symptomatic phase, the longer one delays to inform an individual that may have been close to someone who has symptoms associated with COVID-19, the worse off we are with respect to reducing, in this case, the speed of the disease, measured in terms of the cases per day. Right? And here you can see there's both success in isolating cases, letting someone know that they have to stay home, but also quarantining contacts. Right? So this goes back to one of my early slides that R0 has to do with trying to make sure that individuals who are infected are not interacting with others, but also making sure that one quarantines potentially those who are susceptible or may have been exposed and not yet know it, but then that can reduce future infection. And the earlier one does it, the better off all of us are. As you can tell here, the bulk of these interventions focus on reducing new transmission, some form of closures, lockdown, tracing, and testing. But I want to finish up today with a approach that we've been working on in collaboration with others that addresses the issue that many have already been sick and recovered, and some may have only been mildly sick and recovered and not even know that they've been sick. So could these infections, at a level which we remain thankfully very far from herd immunity, help reduce collective risk? The idea that we have is to try to develop something along the lines of what we term shield immunity rather than herd immunity. And the idea is that large-scale serological testing for antibodies, which provide a history of whether or not someone had been infected rather than a snapshot as PCR does current infections, might both help reduce transmission as well as enable economic development. And I've tried to explain here in two different ways. Population dynamics view on top, an individual view on the bottom. You can find the preprint available on medRxiv or on our GitHub site, and it's in press in Nature Medicine, along with many folks from my group, Sungwoo Park, and from Princeton, and Jonathan Dushoff from McMaster. The idea here is that individuals who are susceptible, if you were to test them for a virus, it would be negative. We remain immunologically naive, and antibodies also negative. And that those individuals, when they become infected, they will have a positive PCR for virus, and the antibodies, depending on when one does the test, may be positive or negative, and there are many kinds of antibody testing, and also even the type of antibodies that may test for might change. And afterwards, they recover and stop shedding virus. The antibodies will be positive and virus negative. The idea is that those individuals who are recovered, if it were possible for them to preferentially interact, in other words, substituting interactions between individuals of unknown status, some of which may be between susceptible and infectious individuals and lead to forward transmission. If an infected individual was instead interacting preferentially with identified recovered individuals, and the recovered individuals likewise could also seek out susceptible individuals, people of unknown status, then in some sense you insulate this SI connection from happening, reducing transmission. So what we've done, then I'll explain the concept here, is that in baseline, again, one doesn't know your status or those in the community, and what we've done in essence is break connections to have limited, whenever possible, no interactions. And obviously there's also a socioeconomic element here, and that's again a topic that goes beyond today's scope, but clearly some people are able to limit and some people may not be able to limit, and again elevating their risk. The hope is that if one could identify recovered individuals, it would help not only them, but actually collectively by reducing the risk of transmission. And again, the takeaway here is that the scale and type of testing matters. PCR provides a snapshot. Are you shedding virus now? It helps to identify infectious individuals. Serological testing, when accurate, for antibodies provides a history. Have you been infected recently or in the past? And we are assuming, and this is a lot of debate on this last topic, that recovered implies immune, though it has to be said that the duration of the immunity remains unknown. If it's anything like SARS, it could be year or more. If it's more like related circulating seasonal coronaviruses, it could be on the order of multiple months. It is literally an unknowable question right now, but operationally, we've been assuming that this will be a longer period, similar to SARS, yet another reason why serological tests are needed. So we have now taken this very simple SIR model, but instead of saying that S and I interact and that there's a probability of interacting with a susceptible individual is just S divided by N, or the fraction of susceptible individuals, here the denominator changes, envisioning that recovered individuals have an elevated rate of interactions, and the elevation of their interactions is denoted by what we call the shield strength alpha. We have different models of it, depending on how aggressive both those who are recovered are in terms of elevating their interactions, and how much susceptible infectious individuals or individuals of unknown status are in decreasing their interactions. Such that depending upon the shield strength, this preference for interaction substitution, it's possible to take something like an epidemic size of 90% and drop it down to 10, 15, 20% or less. Therefore, avoiding ever getting to the point of this herd immunity as the reason for the end of the epidemic, but instead, because a smaller subset of individuals are interacting with others and substituting interactions preferentially, therefore diluting the chance an infectious individual would interact with a susceptible individual and transmit the disease. We've then taken this, and I don't have time to go into all the details today, but applied the same shielding model, not just in this SAR case, but to that more complicated asymptomatic transmission model with hospitalizations and deaths. And the key point I want to explain here is that the x-axis is the shielding rate, the y-axis is the social distancing rate, and you can see here that shielding has benefits at all levels of social distancing, such that it might be possible to consider ways in which trading off essentially by doing less social distancing but more shielding could have the same effect from a transmission point of view. You can see the contour lines as very high levels of social distancing if acted upon on their own. So again, the key takeaway here is combining less intense social distancing and shielding together could have population-wide benefits. How do we find such recovered individuals? Serological testing. And it's something that we and others, including Ben Lopman at Emory, are working very hard on these days to try and realize in practice. So with some closing thoughts here, I think I'm at the end of the hour, and again, apologies for those who came at the outset, who recognize we had some technical difficulties, but also thank you for the many people who told me they could hear me and could see the slides and allowed us to get moving. In terms of some final thoughts, there are many things I didn't get into today in terms of the issue of data quality and uncertainty in terms of under-testing. But I do want to emphasize that COVID-19, despite all those limitations, it has epidemiological features of a high R0, a relatively fast spread in terms of both case doubling rates, but also these generation intervals, and sufficiently high elevated fatality rates and asymptomatic transmission, all of which have increased its epidemic potential. The second thing is that the interventions have already made an enormous impact. The reality is that the situation in many cities, states, countries is bad, with tens to hundreds and tens of thousands of fatalities depending on location. But I also want to point out that through these actions, through these interventions, through lockdown, which have been severe, there's also been the averting of tens to hundreds of thousands of fatalities. I gave you examples both of those estimates in England. I would say the same applies to Georgia. Even though these interventions have made an impact, and even if a peak has been averted in the short term, we remain immunological naive, and we should not therefore think that a return to business as usual will mean that all will be well. So my last thoughts are really ones in looking forward, with some optimism that testing, which is still underdone, but if one thinks about testing in terms of both PCR and serology, looking at virus and antibodies, and initial efforts along those lines have shown that in some cases there may be populations or subpopulations that have 10 to 20%, many of which are asymptomatic. And therefore there's an opportunity there for both reducing new transmission, but also thinking about leveraging serology to enable shield immunity strategies that are part of strategic efforts. And that's really my last point. Strategic and coordinated responses are needed. This is a global pandemic. So whether thinking about the United States, if Georgia does one thing and Alabama does something different, both states will be at risk. We have a long road ahead. We'll be better off working collectively. And I hope the slides today have given you some perspective, both of how we got here, the foundations of how we got here, and how folks are thinking about moving forward for a collective benefit. And with that, just want to again thanks my team. It's 4 o'clock. Code, preprint. You can see more about shield immunity on my tweet thread. And again, thank you to funders for their support of our work.
Josh, as everybody else is muted, I say on behalf of everybody, thanks for the wonderful talk. I really learned a lot. And now, do you see the question feed on your, Josh?
Yeah, I'm going to try to now move into the Q&A.
Yeah, Q&A. Do you see it?
Yeah, so let me talk about one.
I'm moderating this question, but you answer them. There are 3 of them right now.
So I'll do them in the order that they seem to arrive. The first one, and I'll repeat them, was how does shield immunity differ from herd immunity? Is that the dynamic nature is something fundamentally different? So it does differ. keep in mind that herd immunity operates because of a depletion of susceptibles. Shield immunity is elevating the contact rates of recovered individuals relative to those of unknown status, such that depleting the probability of an SI interaction rather than depleting the population of susceptibles. So it really is dynamic in nature. It acts as a negative feedback loop. It also is local in scope, meaning places that are unfortunately harder hit have more recovered individuals who could potentially act to function to have this population-wide shield immunity. Details are in the paper, but I hope that gives some sense of an answer. The next question is, what is the best long-term strategy, assuming no vaccine is developed? My brief answer to that is simply there's no silver bullet. So I would say that a collection of strategies are going to be what's needed. They may be local in scope. Testing is key, and I just want to continue to emphasize that the reason why we're testing is not to make anyone look bad, though certain people should look bad because they've done a terrible job in terms of trying to really get ahead and support efforts to identify the scope of the problem. But insofar as that one uses testing to identify who's infected, use that to de-risk contacts, use serology to understand who may have been recovered and protective antibodies. There are many other benefits of testing for serology. One has a better idea of the incident fatality ratio, understand real age-specific and even job-specific risk. There are also benefits for convalescent plasma. And there are other strategies in terms of being strategic about the use and extent of different kinds of ways that we go about our business but reduce contact, whether that means continuing contact-free deliveries, whether that means in different kinds of industries it may be that alternating or having different approaches to how people sit, how people interact, having more monitoring, having people monitor their temperatures, having symptoms over multiple days. There's not going to be a single best answer. It's not even just the absence of a vaccine. We don't have at present a reliable therapeutic to treat those who are infected if they do get infected. So I'm sorry, Roman, I don't have a better answer, but I think that the answers are going to be a combination of strategies. I don't have a good answer on ways to improve our immune system. I'm not a medical doctor, and with respect to chloroquine, I think there's a lot of evidence that there's no evidence of efficacy. Beyond that, I am not sure what to say. Could mutations emerge in different parts of the virus structure affect the development of vaccines? Samiksha asks. It's an excellent question. Trevor Bedford has covered this at length. And just to be very clear, the virus has already mutated and evolved many times over. It's in fact the mutations of viral strains, and you can go to nextstrain.org, and I'll in fact just type nextstrain.org as a great way for people who are interested in understanding virus evolution, that it's unlikely that any of these mutations that have emerged thus far has affected things that we think are going to impact vaccine development or other ways really impact core epidemiological traits. But they do help to identify the origin of a virus. So for example, in New York, there's thought that most of the imported cases were coming from Europe rather than from China, whereas in Washington, they were almost certainly coming from China. And so we can use phylogenetic relationships and evolutionary relationships between viral genomes as a way to place origins. But at the moment, I don't think there's anything that indicates that anything unusual is happening here from an evolutionary perspective that would affect either vaccines or traits. That doesn't mean that it can't happen in the future. The percentage, the next question has to do with recovery and immunity. I want to be very clear there that I'm not convinced that that's true. There's been conflicting reports on reinfection. It's very important to keep in mind that a PCR test could be positive, negative, positive for someone who has not been reinfected, but rather has varying viral load. And so I think it's important not to confuse the two. That at the moment, there's not any evidence of reinfection. Once someone has acquired neutralizing antibodies, do we know whether everyone acquires neutralizing antibodies? No. because we haven't done enough serological tests. The other thing I want to point out is there's a question about the prevalence of asymptomatic. I think that right now the idea of asymptomatic prevalence is one that some people think is on the order of 10 to 20%. It could be even higher. To the extent to which an asymptomatic individual recovers and develops protective antibodies, then yes, serological tests could identify them. And in fact, doing serological tests, not just on those who had critical infections, but doing them in whether population-wide surveys or even within industries would also be quite important, because then you're going to begin to answer that question. There's a few more, and I don't know, maybe we'll go on for a few more minutes. I'll try to go to 4:15 and then we'll close it. Is that okay?
Okay, I mean, people can just leave, people who are interested will stay.
So why don't I say that I'll go to 4:15. That's about 7 more minutes, and if folks need to go, that's fine, but I will continue to try to answer the questions.
I have bad news for you. All the 30 people left, but the 100 that are still hanging in, you have them.
That is fine. I'm not sure if
and you
that's good
started
news.
late, so you have some time. Go ahead.
Thank you. So for those who are on the call, I'll go to 4:15 and then feel free to follow up. Aradja asks, what is the most efficient ways to use testing right now? I think there are different questions we can ask with different strategies. So clearly, there are ways to use PCR tests on individuals who may have been close to individuals who had a positive confirmed case. On the other hand, one could also think of just unilaterally saying that individuals, if you were contact traced and recognize that you were close to someone who had COVID-19, then you should go into a period of self-isolation. But we're all in lockdown, so it's not sure that that's getting that much of a difference. The advantage, though, of really it's the different kinds of strategies tell different things. A population-wide, for example, serological test will give us one set of information, but we have to worry about specificity. But if we were to focus on groups that are likely to have even more prevalence, we're more likely to pick up asymptomatic cases at a higher rate by targeting particular groups. And in our case, with shield immunity, if we want to think about ways that we could strategically utilize individuals or have them benefit collectively reducing transmission risk, then actually focusing on groups that are likely to have an elevated case rate is probably more strategic than doing population-wide surveys. There's not just one good answer there, but I think people should be asking themselves, how can the test strategy help to answer the particular question they want? There's another question about reinfection. Yes, Hema, thank you I addressed it to some extent. I don't think we should interpret reports of reinfection yet as meaning that immunity is that short-lived. From what I've understand, and I've been following Florian Kramer from Mount Sinai, who's thought about these things, but again, we need to be careful that PCR can be positive, negative, not because someone fully recovered, but because they had a negative PCR test in between two positives. There's a few more questions, and I think we're getting to the end here. There are real questions to ask about spending, and I just want to point out a very simple thought experiment. Right now, the U.S. has had multi-trillion-dollar stimulus packages. The cost, when you do blood work of a typical serology, we don't have this at scale yet, so I get that, but typical laboratory work for serology is not expensive, $20 or so. If every American had a serological test at some point, it would cost $6 billion a year. Right? So just to point out that we're talking about thousands more in scale, but testing is one in which right now we can make a difference. I think before I'd worry about future outbreaks, and you want to have better sensing systems and communication systems and so on. Right now, testing should be thought of as part of our arsenal as an intervention, whether it's viral testing or serological testing, and not as something that we don't need to do because maybe it would make someone look bad. We need to know the truth, and the truth with respect to the extent and prevalence and localization of cases is going to be helpful in devising better strategies. And I think we're almost done here with 2 left. Yeah, the value of tests also depends on how quickly the answers are returned to you. And I gave an example of the work of Christoph Fraser of how quickly we could operationalize information on symptoms consistent with COVID-19 or a test has a radical difference on the impact of the spread. The faster that we're able to reliably get information back, the better it is in terms of reducing future transmission from people who may have been exposed and not know it. And I'm not going to give a particular answer to some more questions back here about recovery. Individuals, I think, who recovered from COVID-19, would it be beneficial to see the person, better to not see? I'm sorry, I can't give you a particular answer with respect to not knowing all the details. I'm also not a medical doctor. I would recommend those people talk to a medical doctor. But in general, at a population level view, one of the reasons why I think serology matters is that we need to know those kind of answers more generally. To what extent is it that individuals who have recovered, who we've assumed are going to be immune, how long they're immune for, is that true for both symptomatic and asymptomatic cases? Mark Lipsitch has a wonderful New York Times editorial about this just recently. And again, we need to start scaling up serology now. And then the last question, I think I'll call that the last question, then call and just thank everyone. Ilan asked if there's large variation in transmission rates, how that affect forecasts that are coming out of largely mean field ODSIR models. This notion of dispersion is actually built into a number of these models. And the thing about dispersion is that when there's dispersion, for example, in terms of timing, it often means that individuals are transmitting earlier, which means that, in fact, given the same observed rate of spread, it's likely that the R0 may actually be lower. The other thing, though, that makes it more difficult, that's maybe good news. The negative news is that there are many features of how COVID-19 spreads, whether it has to do with aerosolized transmission or concentrated super spreading events, in which it's clear that those kind of large events will also make it very hard to do the forecasting. These forecasts often take populations and subdivide them into different groups, but to get all the way to the granularity of these sort of network models or stochastic models, once we are in this kind of large-scale event, these mean field models often can be quite good. But in thinking about how do we de-risk or reduce large transmission events in particular, aerosolized events, or that case of a chorus, or the Biogen conference, those are things that we need to think very hard about. How do we reduce large-scale tail-like events where we have the potential to be in a good place, and then all of a sudden a funeral like in Dougherty County near Albany, or that choir event, or the Biogen conference leads to a large transmission, and we have to impose large-scale measures again. So I think that's one of the ways in trying to figure out these large variation, big events, what is the transmission mode in which they're most correlated to, and how do we reduce that risk? And with that, I guess I should stop. So thank you, Predrag. Thank you for everyone who attended. And happy to follow up again with questions. Thank you for taking the time today.
Okay. On behalf of all audience, thanks a lot. This is very, very helpful and informative. For people who know people who would like to see this presentation recorded, it is recorded, and Joshua will announce on his Twitter feed where the link to this. It'll take us a day or two to prepare it for uploading. Thank you, everybody. And that's it. Stay safe.
Thanks.